Hello, everyone. I hope you are all well. Thank you so much for joining. My name is Farah Dimashqi. I am the head of Quality Research and Development Unit. I am a nurse and a public health professional as well, and I will be co-chairing this session along with my colleague, Hala. We both are presenting Sanad in this event, and this event is taking part in the London Cancer Week, which started yesterday. And we are very happy and privileged to be here with you talking about palliative care in collectivist and in crisis settings. Hala, are you with us?
Yes, Farah. Thank you. My name is Hala. Let me introduce myself. I am a nurse. I work as a quality and training officer at Sanad. I have a background in quality, and I'll be sharing the session today with Farah. I'm very happy you are all attending this session and looking forward to it.
Okay, we are hoping that we will spend together 1 hour. And if you have any questions, please put them in the chat and we will address them at the end of the session. I just want to give you as well a background of this session. So this session will focus on the experience of Sanad, which is a home hospice organization, over the 15, 16 years that it has been working for in Lebanon, handling palliative care and end-of-life care as well, and talking about this topic in the lens of collectivist societies and in the lens of crisis settings as well. So we hope you enjoy it and we hope we have a fruitful discussion at the end of it. Also, to let you know that this session is being recorded. It will be as well put at the end of the event on the websites of London Cancer Week and, of course, our website. Um, okay, so let's start. Okay, so but let me give you some background about Lebanon, whoever is not from Lebanon. So Lebanon is a small country which is located on the eastern coast of the Mediterranean Sea. We have a population of an estimate of 5.8 million, and we are rich with our history and cultural diversity. And despite the economic and political changes that the state have been witnessing since the past 5 to 6 years, the healthcare system and organizations have been continuing and doing their best to demonstrate and dedicate their services to improve access to healthcare services in general, high quality services in specific, and including palliative care and end of life care. Just to give you some background about the need for palliative care in Lebanon, so it is estimated, according to the database of the serious health-related suffering, that around 31,000 people in Lebanon each year suffer from serious health-related suffering and as such would require palliative care. In specific, in relation to cancer, it's estimated that we had 11,800 new cancer cases in 2025 and 6,800 mortalities from cancer. And according to the latest atlas that was released on the Eastern Mediterranean region, palliative care in Lebanon was described to be progressing, and it includes 14 specialized palliative care services that has both home-based services and hospital-based services. However, unfortunately, a lot of them are concentrated in the capital Beirut city or in mainly urban areas. On the other side, Lebanon yet is to still integrate palliative care in its reimbursement or financial reimbursement system. It isn't yet fully there. However, a lot of work is happening to push for this to happen. So just to brief you about the situation of palliative care in Lebanon and how it did progress. So the a lot of details more to add to this slide. However, this is a summary of the most important milestones. The services started in 2010, mainly home-based hospice NGOs started the services where no services were available before. After that came the establishment of the National Committee under the Ministry of Public Health. After that, palliative care was considered a medical specialty. And moving forward, a national cancer plan was launched in 2023, which we proudly took lead in as well. And it has a chapter on palliative and supportive care. And we are currently part of the organizing or the advisory committee of this cancer plan. And we are leading with other palliative care organizations the work on this chapter. The latest updates in terms of Lebanon is the work on the reimbursement plans that's happening as part of the National Cancer Committee work, where we are pushing for insurance companies to start covering for palliative care services. At the moment, in Lebanon, home-based palliative care services are not yet reimbursed by any party. So to give you an overview about SANAD as well. So SANAD, the Home Hospice Organization of Lebanon, is an independent, non-governmental, not-for-profit, human rights-based organization that was established in January 2010. We are part of the National Committee for Palliative Care, and we are part of the National Cancer Plan that I have just spoke about. Our mission is to provide free of charge home-based hospice services for patients who are in their end of life phase, mainly who have terminal or life-limiting illness in their last year of life, and we aim to assist their this period and their family to remain as alert, as functional as possible within their the calm and the sanctuary of their own home. And we do deliver this service to patients who are of any diagnosis, any nationality, any religion, any gender, and regardless of their ability to pay. We do cover two areas in Lebanon. We work in the capital, Beirut, and we cover Beirut, Greater Beirut, and we also work in another city or governorate, which is Bekaa, and we cover mainly Mid Bekaa and hopefully West Bekaa as well soon. This is our beautiful team. Just to tell you that the Sanat team started as only 3 people, very small team with very basic financial resources. And now we are as huge as this picture shows. And we have seen more than 2,500 patients so far since we started until now. We see patients who live with low life-limiting illness, and if they have a competent caregiver at home, and what if they live within the geographical area that we cover. This is our admission criteria. So now we're going to present some data about our work, but we chose to talk about the last 5 years just to make, because of the data, we selected the most consistent at the end because there were some changes in how we collected some indicators. So we chose 5 years because that was when it was lastly changed. So in the past 5 years, we saw around 1,492 patients who were distributed like this. So roughly, they were 51 females, 48 males. Most of them are old in age, which is more than 70 years. They presented to us with a median palliative performance scale of 40. Majority of them are cancer, 96%. We did start seeing non-cancer since around 2 years. However, the percentage is still, of referrals is still low. And we are happy to see that most of our patients do die mostly at home, 76%, and their length of stay so far in the last 5 years have been 27 days. This stay duration has been increasing with time slowly. However, we definitely hope that we see longer durations with us, and we see short length of stays. Talking about symptom burden, so we wanted to highlight how the hospice care in Lebanon is able to really make a difference in terms of symptoms. We looked at our symptom burden using the ESAS tool that we use to assess for symptoms, and we looked at admission burden versus a second visit burden and looked at how this is different. So upon admission, we had in the past 5 years burden of 26 that has changed to a burden of 12, which is more than half. It has decreased. This is just after the second visit. We also looked at what are the common symptoms that we see upon admission, and that was mainly poor well-being, tiredness, and lack of appetite. And looking at the severity of symptoms. However, it's a bit different when we look at it from how severe is the symptom. In terms of severity, we saw that insomnia, constipation, and pain were the three symptoms that were most severe upon admission in terms of score or severity. So these are the symptoms where people or patients scored them as high, which is 7 or 8, 8 or 9 or 10 over 10 when it comes to the ESAS scoring. Looking as well specifically at pain, we looked at upon admission how many people reported pain, and after 48 hours, how many people reported being comfortable from pain or where pain has been controlled. So we have 99.6 of our patients reported being comfortable after 48 hours of admission in relation to pain. We also wanted to show the impact of hospice care when it comes to how caregivers are satisfied after the service have finished. So we do send a survey to caregivers in order to assess their satisfaction after the death of the patient in around like 2 months or 3 months. And we look at composite scores that are part of the very famous CAPS tool. And this shows the scores in relation to different aspects: communication, getting timely help, respect, emotional support, help with pain, training family, giving enough information before death. And the green bars are the ones that are top scores, which means that the families were super satisfied. Middle are like middle satisfaction. Bottom is like the low satisfaction. And as you see, most of these scores are very highly satisfied. And this also shows that hospice care plays a huge important role when it comes to improving quality of life of patients, and caregivers as well do perceive this very clearly even after the death of the patients. Also, just to complete the picture about Sanad in relation to our model. So in addition to, of course, the service that is the core aspect of our model, providing the service at home to patients, we also have been involved since 2016 with some capacity building work. The aim of this work was to share knowledge and experience with other organizations and other healthcare professionals to support them in developing their own palliative care services. And this falls as well under the social impact pillar that Sanad has as part of our strategic plan. And we did develop two programs, one a specialist to help organizations develop a specialized service, and one as a generalist where we aim to help healthcare professionals use palliative care principles in day-to-day life in their daily routine practice. We did work with several organizations in helping them develop their specialist services in Lebanon and the region, a total of 8 organizations, which we are very proud of. And we did help train healthcare professionals, around 500, since we started in 2016 till now, to help them integrate palliative care principles into their routine practice. We are also proud to say that this training program, both the specialists and the generalists, have won the UBCA EAPC Leadership Award in relation to capacity building in 2023. In addition to this, we also work on research, and part of our very recent project that is research and service development oriented. We are currently working on identifying the need and understand the situation of palliative care in camps, in Palestinian camps in Lebanon. This is quite a big project that has started around 1 year back. We are in the end of the research phase, where we are exploring the need, understanding what's happening in the camps, in order to help co-design with the camp community a model that would allow for palliative care to be integrated at different levels, both primary and community and a specialist level. So today we wanted to highlight two main topics. which we think are worth of highlighting when it comes to palliative care. We do know that palliative care is not the same everywhere, and it is adapted to the context and the culture of countries and societies. And we wanted to highlight on two topics: truth telling, one of them, given that Lebanon is a collectivist society, and crisis setting. I will be covering truth telling, and my colleague Hala will be covering the crisis setting. So, regarding truth telling, I think a lot of people, if they come from collective society, would resonate with this, but we do know that it is not that easy to come and talk about diagnosis and prognosis with patients and families when it comes into palliative care. And we do also believe as healthcare professionals that we think this is a very important topic in palliative care, and it is not that easy to do palliative care without doing this topic or without implementing this aspect. However, in our societies, we did not find that things are very straightforward, and that there are several factors that factor into how we do truth telling. So, in collectivist society, we know that families do play a role in influencing the dynamics of truth telling and whether doctors talk about this clearly with the patient or not. Usually, out of protecting the patient, families try to not to tell the truth and ask the doctor not to say about the diagnosis or prognosis, or not to give all details. uh, we purely know that the family try to do this out of love or out of protecting their patient. And we also know that this topic is not very researched in Lebanon or even in the region as well. There are some studies, we'll cover some of them just to give some context. So in a latest systematic review study, there was a study that was done on that included 23 studies that looked at truth telling in collectivist societies. Mainly the studies came from China, and the study looked at the impact of truth telling on quality of life, physical symptoms, functioning, role functioning, cognitive activity, emotional functioning as well, and found no difference between those who knew and those who didn't know. And they also found positive difference where they saw that the patients who knew have higher vitality compared to those who didn't know, and those who didn't know had lower social function scores. So here we are. What are we trying to see? We are trying to look and see, does really truth telling impact patients negatively or not, or does it impact positively or not? To address this challenge in our societies, and studies are still showing us that there is not a negative impact, such as this systematic review, and it is on the other side showing that there is positive impact as well. So this pushes more to a conclusion where probably it is better to say the truth. But of course, there are many reasons that there are many factors that get into the way in this. Another study that was not included in the previous systematic review, because it happened after the systematic review, is an interesting study that took place in Egypt, but however, it is only a cross-sectional observational study. It included around 300 cancer patients, and they concluded that the unawareness of the diagnosis did not associate significantly with anxiety, depression, and quality of life upon conducting multiple regression. We also did, as part of the needs assessment that we do when working with other organizations to develop their own services, we usually do a survey before that with community members or with patients who have palliative care needs. And we did notice over several needs assessment exercises that we have done, whether in Lebanon or in other countries, that people do want to know about their diagnosis and prognosis. It is not that they don't want to know. And in one assessment that we did with older adults in Qatar, it did show the same. We did look at patients and caregivers and compared them, and it was always obvious that patients who are older adults wanted to know more and compared to the caregivers. So caregivers tend to be protective. Patients do want to know, and this difference in this study was significant. In Sanad, when we receive patients upon admission, we also look at whether they are aware of their diagnosis and prognosis. And over the 5 years, we had almost 57% of patients aware of their diagnosis. However, we have 37 who are not aware. Looking at the prognosis, we have 47 who are aware that they have a serious and terminal illness. However, the rest, 22.5 only who are aware that they have seriously and terminal illness. However, 47 would are think that they are seriously sick. However, their sickness is not terminal. So this is also an indicator that people are not being given all the information that they probably need. However, what we are calling for in this aspect, so definitely we are not calling for enforcing all the Western model as it is, because we know that it doesn't work as it is, because the definitions of autonomy and how things work in collectivist societies are different from how things are defined and looked at in Western cultures. However, what we found is helpful in our practice, and now the research is heading towards such conclusions as well, is that we really need a relational approach when it comes to truth telling, that is based on building trust with the patient, building trust with the family, and this trustful relationship will help in doing discussions more easily without resistance, and with showing the core importance of why we are doing this work. We noticed that, like, for example, in Sanad, when we see patients, many times, families tell us at first, please don't tell our patient doesn't know. We really don't resist that. We do accept this. However, we tell them that with time, we will look at how patients are doing. And very important thing that we do when we see patients is understand what do they know about the diagnosis and prognosis, understand from them what they have been told, and see if they want to know more details and information about the diagnosis. And when they say that they have questions and they are anxious, we do sit with the family and discuss these concerns that we are seeing with the patient, and discuss the importance of telling the patient and how can this improve their quality of life. And in almost all the times, this approach does work. We eventually we eventually do break bad news and discuss prognosis with patients after discussing what we will do with the family. And all the time, this results in good outcomes where patients feel better, feel more in control, and families eventually do see the benefit of patients understanding what's happening. So we are really calling for an approach that is tailored to the individual needs of persons. There are some people who don't want to know much information. There are others who do want to know details. It makes them feel in control. So we are calling for an approach that is very, very, very person-oriented and relational in nature, where the trust relationship with the patient and the family would allow a positive outcome in relation to this. One last thing I would want to say, that families do highlight and patients do really highlight how much truth telling has been stressful for them. And this all goes back into the way that the clinician have done this breaking bad news, and they describe very difficult scenarios and stories where the clinician was not sensitive, did it in a rush. So all these factors are very important when we do breaking bad news, following best practice guidelines such as spikes or others, and they do make all the difference when it comes to the impact of truth telling on patients and families. I will now give the floor to my colleague Hala to go over the crisis section.
Thank you, Farah. I just want to remind everyone, if you have any questions, please leave them in the comments section. We will get back to them at the end of the session. Can I get access to the slides?
I did.
Oh,
Let me know if it's working. Okay.
So after going over the truth telling and the collectivist cultures section, I'd like to talk a little bit about the broader context that shaped how palliative care services were being provided at Sanad and in Lebanon over the past few years. So since October 2019, Lebanon entered one of the most severe economic collapse at a global level. We saw rapid currency devaluation, banks imposing restrictions on withdrawals, inflation skyrocketing, and living standards declining at record speed. So the collapse didn't happen in isolation. It was also compounded by the COVID-19 pandemic and the Beirut port explosion in 2020. According to the World Bank, Lebanon's crisis ranks among the most severe worldwide since the 19th century. And in June 2022, unfortunately, Lebanon was officially reclassified from an upper middle income country to a lower middle income country, which reflects the depth of the collapse. So what happened? We all lived through the consequences. Banks closed. We had limited access to our own money. There was skyrocketing fuel prices, severe electricity cuts, sharp increase in food and basic goods and their prices. So essential services, including healthcare, were also disrupted. The healthcare sector was hit especially hard. Fuel shortages forced some hospitals to publicly appeal for donations just to stay open. We witnessed a massive migration of healthcare professionals, which created an additional shortage of staff, and medication became very difficult to access. I'm not only talking about chronic medications, but also about essential palliative care drugs. So in oncology, a study showed that 32% of oncology patients at some point they faced treatment interruptions in 2022 because their treatments were not available. And the Ministry of Health, who had financed cancer medication for 2008 and 2013, was able to cover around $6,000 per patient, was no longer able to cover these drugs. So they were not covered for them anymore, and they had to pay out of pocket when they were able to. So these shortages combined with financial hardship and reimbursement issues in the hospital and all of these problems, they made healthcare inaccessible for many people in Lebanon. Even when the service existed, some people were not able to afford it. So the crisis reached every part of the care continuum, from primary care to tertiary care. There was a major gap in access, and especially for vulnerable patients. So for Sanad, how did the economic crisis affect us? There was concrete operational consequences for the economic crisis on Sanad. We had fuel shortages and road blockage due to protests, which limited our ability to travel for home visits. Medication shortages complicated symptom management for the patients, and we faced staff retention challenges due to the migration and significant brain drain at the national level. Communication networks were unreliable, which made telehealth even more difficult. And not only patients and family were financially vulnerable, but the organization as well. Sanad's funds, unfortunately, were subject to devaluation with a risk of unsustainability of services. All of this, sorry, can you see my slides? Okay. All of this led to an increase in referrals due to higher demand for free of charge services. And at some point, we reached a peak where the hospice team was really overwhelmed by the number of referrals, and we had to put a limit for our nurse to patient ratio to be able to ensure high quality comfort care. Moving forward, we had the COVID-19 pandemic, and when the COVID-19 hit, Sanad had to rapidly restructure the operations. We strictly adhered to the infection control guidelines. We implemented telehealth support for stable patients who were asymptomatic to reduce visits as much as possible, especially that our patients are mostly from the vulnerable high-risk population. As for the active and symptomatic patients, there was a process for phone screening, and home visits were conducted only when the screening was negative. As for the positive screenings, patients were either redirected to the hospital or followed up by telehealth sessions, depending on the case. For mental health support, it was continued, but it was being done online. And in-person sessions were reserved only for urgent cases that screened negative for COVID-19. Okay, so the pandemic also created internal operational pressure inside the organization. Why? Because PPEs were very expensive, as well as sanitizers, and sometimes even unavailable. We had staff absences due to sick leaves and quarantines. We had to constantly adjust the infection control requirements as guidelines evolved on a daily basis. And of course, the mental health burden grew, not only at the patient level, but also at the level of staff who were handling a lot of fear, uncertainty, and exhaustion. So we had to adapt and to respond to these crises, whether it was the economic or the COVID. So what did we do? So to ensure continuity of care during both of these crises, Sanad implemented several adaptive strategies. So in service delivery, we shifted to needs-based home visits, and we used structured phone follow-ups or telehealth consultation, and we expanded caregiver education to empower family caregivers. At the operational level, we established agreements with fuel stations to solve the fuel shortage problem. And we updated our contingency plans on a daily basis. And we made sure that our teams adjusted their route to avoid areas of unrest as we coordinated at checkpoints during a road blockage. In addition, we allowed work from home arrangements to reduce commuting as much as possible for our staff. And we even produced in-house alcohol-based disinfectants after consulting with experts to solve the problem of shortage of disinfectants. We also collaborated with other organizations by sharing PPEs, medications, and even internal policies, and we co-organized a regional webinar about palliative care response to COVID-19 with the WHO EMRO office. Finally, donor support and fundraising were essential during that period of time, and establishing an overseas bank account helped us protect donations and sustain Sanad services for patients. Okay, so these are the series of webinars done by Sanad with the WHO EMRO office during COVID. And of course, we had special fundraising events planned for whether for the economic crisis or for the COVID-19 pandemic. So fast forward, and while we were still struggling with the consequences of the previous crises and the ongoing economic hardships, a devastating Israeli aggression between September and November 2024 resulted in more than 4,000 deaths, including 200 healthcare workers. So at this time, pressure on the healthcare system was increasing, and the displacement was spreading across the countries. Medications were interrupted, and the infrastructure of healthcare was damaged. Both Sanad's operational areas, which are Beirut and Bekaa, were constantly being targeted, unfortunately, and that created direct service disruptions in both of our operating areas and increased the risks for our staff. So what happened during the war? Unfortunately, it led to displacement, not only among our patients, but also among our staff. Patient referrals decreased. It was not because the need was lower, but because access and communication were very difficult at the time. Security risks were constant, mobility was limited, and the emotional burden on hospice staff increased drastically. So how did Sanad respond to these events? Our response during the war focused on operational flexibility and staff well-being. So in summary, we updated our contingency plans on a daily basis. We suspended all our after-hour visits due to security reasons. And we went back to the work-from-home arrangements with clear task monitoring processes in parallel. And telehealth became very essential for our patients, especially those who are at high risk or restricted areas. We also coordinated with other NGOs to identify palliative care needs in displacement centers, so patients who have this type of need in displacement centers, to ensure continuity of care for those patients. Unfortunately, it was easier for them to find us than for us to find them, because even though local authorities were very cooperative, they were really overwhelmed by the magnitude of the situation at the time. And equally important, our mental health unit provided group and individual debriefing sessions to support staff during the difficult time we were going through. So what did we learn from past 5 years? I would first like to start first and foremost with organizational resilience and adaptability. Because really, we learned that organizations that are flexible can continue to serve even under extreme pressure. Quality improvement in such situations becomes a resilient strategy, and resource scarcity pushes us to find creative solutions. It was not only about how to survive the now, it was about reframing and strengthening the service for long-term care. Second, community-centered services were vital. When institutional care was disrupted, community-based and home-based services became the safety net for the patients. And empowering caregiver allowed us to build their capacity and to foster trust and eventually to improve outcome for the patient, which is especially important when resources, and by resources I mean especially the nurses, doctors, and psychologists were stretched too thin. Third, the workforce. We learned that the workforce is the backbone of every service. So staff well-being, resilience, and devotion determines whether a care can continue or not. This means emotional support, debriefing, and self-practices must be permanently integrated in every response strategy. And finally, coordination and preparedness really matter. Strong partnerships with the Ministry of Health, with other organizations, or even with international organizations can create an impact and reduce operational challenges for everyone. So having a risk mitigation and emergency preparedness plan makes the difference between collapse and continuity. Finally, I would like to conclude by saying palliative care is universal in its need, but specific in its execution. It must always be shaped by the cultural and economic context of the country. So if there is one message to take home, it would be this. Adaptation is not optional at all. It's essential for success and for safeguarding compassionate care, no matter what the circumstances were. Thank you so much for attending the session. And let's move to your questions.
Okay, so there are some questions in the chat. I was going through them. Um, there was a question from there was a comment from Dr. Nahla saying that great efforts and on the insurance coverage. Thank you, Dr. Nahla. We are hoping that this works out, to be honest. Fingers crossed, as they say. Would you like to add anything, Dr. Nahla, on this?
Yes, thank you so much for this wonderful presentations, both of you. It gives us a lot. I think what Senate is doing is something that can be replicated and can a lot of other associations and even people who didn't start yet to learn how to start services, how to improve them, and how to document the success. I would like to mention, I think this point, if you can do it, this insurance, it will really solve the problem of how can we provide palliative care when it is not so expensive, when it is a quality service, it is so much needed. Like we celebrate the birth of somebody. Why don't we celebrate end of life care? Why don't we provide this care, which is so essential? And if anybody is asked if would they like to suffer at end of life, nobody will say no, but they don't think about that. They want to buy a Gucci bag, they want to travel, but this will cost so little, and solving it through this way of insurance or health coverage, I think that would be great. Thank you so much.
Thank you, Dr. Nahla, for your very valuable comment. Yes, definitely. This is what we and other organizations are working on and trying to push for. let's hope that this move forward. There is a lot of lobbying and advocacy by several stakeholders working on this project, and it is definitely a priority. So, hoping that this happen. So,
Good.
also to mention that at an earlier stage, around before the crisis started, the Ministry of Health did issue a decree for reimbursement for people who are under the Ministry of Health coverage track. However, this did not go into effect because the crisis started just afterward and was not put into effect. We are also hoping that at some point this will be revised and will hopefully get implemented. So there is an intention, obviously, more than any time ever, of course, but the devil sits in the details. So let's see how things will go.
Great. And once you are successful, please tell us more. And I think I can link you with APCA here because they can advocate for this approach also in African countries. Thank you so much.
Okay, excellent. Thank you, Dr. Nahla. There was a question by Anika about could you inform us about the average number of visits an enrolled patient may receive from Sana team, considering the average duration of enrollment is less than 1 month? Okay, good question. Okay, so we do, there is a straightforward answer for this, around 6 to 7 visits, but there is a more detailed answer to where did the 6, 7 come up from. So what we do is that we have an equity tool that we use that gives a score for each patient every week or whenever his need change. And this score is linked to the frequency of visits. So this is an equity tool that has 5 levels, and every level is linked to one frequency of visit. And it depends on what the score of the patient is for this week or for this day. So let's say the patient is is relatively stable. Let's say his score is 2, and then he gets one visit every 1 week or other week. Let's say he is less stable, so his equity score is 4. He gets at least 2 to 3 visits, and this is a minimum number, so it might go up as much as needed. So based on this tool, we were able to, so the practice is really influenced by this tool, and this tool guides us on how to conduct visits. And then we do the math, and then we produce an average or median number of visits per stay, which is around 7 to 8 visits.
Nakuja. Acha niweke hiyo.
Okay, I'm not sure if there are any other. Bibi is saying wonderful, amazing, how much you guys achieved in just 10 years. Yes, yes. I think this is when multiple factors and multiple stuff goes like combined together, then you would get a result where the impact is greater than the number of factors that you get, so it gets more exponential. So I think that's a main reason probably, and definitely the enthusiasm and passion of all people working in the team, definitely including the management.
There was also a question by Lamia. She was asking which organization is the primary source of information on palliative care. Was there anything before that? No. There are many sources of information on palliative care, Lamia. I can give you some examples so you can find information on palliative care on EAPC, CAPC, NCCN. You have many WHO. You have many sources of information, also the IAHPC. They are very valuable sources of information on palliative care. Razan, is Sanad planning collabs with EAPs? And the second question, what are Sanad's plans for raising more awareness on hospice care as we see a huge opportunity to improve? Good questions.
I wanted to ask, what are EAPs?
Yeah.
Sorry. Maybe I can explain that, please. Sorry.
Sure. Go ahead.
So EAPs are corporate programs that are targeting employee well-being. So I heard the question about insurance, which is very valid. However, with the bureaucracy surrounding insurance and the slow progress on that, EAP can move faster. So this is what we call employee assistance program that helps employee mental health, physical health to a certain extent, etc. And these are programs available through different providers.
Okay. Okay, that's interesting. Do you get a lot of employees who are sick or have illnesses that can benefit, like have serious illnesses that can benefit from such like an approach, palliative care?
So the idea behind the AP is to provide this support to them. So, for example, if I'm an employee, and the reason I'm asking this is because I work in HR, and these are the benefits that we like to offer to people.
Okay.
If I'm an employee and I have a sick parent, I have access
Okay.
to a certain app or a provider that supports me free of charge if I'm personally, or even if my parents are struggling from this illness, this terminal illness or any type of illness.
Okay, okay, got you. Okay. Honestly, this is an area that we never tapped in, but we can definitely explore further with you if you want to keep your details, and we can definitely approach you and see if we can do any, like, if there's any areas for collaborations, we would definitely be privileged to do that. Um, but yeah, definitely an interesting idea. And you also had a second question regarding
Yes,
raising awareness.
awareness
Yes?
raising. Yeah.
Yes. Hala, would you like to take that?
Oh no, go ahead, Farah.
So yeah, we've been doing a lot on that, but as you said, there's a huge need. So the more you do, the more you need to do as well. But we do always have regular awareness raising activities that come up throughout the years. But we do have one specific that has been going with the Ministry of Health along with Balsam, who is the other organization we're working with under the National Cancer Plan. And we have done several awareness raising activities that are national, on a national level, covering different areas in Lebanon. We also had one 2 weeks back with the Order of Nurses, who with the society, Nursing Palliative Care Society, which we did as well, and the Lions Group, which we did in Bekaa. That was really a very interesting one. So the need is huge, definitely, and we are working on that. We also have a huge, excellent social media component that we use in our work in Sanad. So there's a beautiful communication team who has been working day and night to produce easy, understandable, relatable content in Arabic to help in increasing the need, like increasing the awareness about the need and what does palliative care. And I would also say something about a new project that we have released, which is called Stories About Sanad, or Hikayat min Sanad. We are using, of course, after the okay and permission of patients and families, we are using the content of the stories of patients in order to shed light on the stories of these patients and how did their life change when they did receive palliative care. Why are we doing this? Because we know that stories are very effective when it comes to in changing attitudes in relation to awareness raising. And when you hear a story and see what happened, it changes how you think about stuff. And we are trying to tackle very debatable topics, so such as truth telling, the topic that I've talked about. So we did release an episode about truth telling. I would these are provided on the social media. You can definitely go and access them. They are on Instagram, they are on YouTube. So they are videos that are 6 to 7 minutes, made in Arabic, very easy language, very close language, what people speak and say. And it does talk about debatable topics such as personhood, truth telling, taboo stuff that we don't talk about, talking about death, etc. We are hoping as well that this project will help in reshaping how do people look at palliative care, especially community and lay people. So this is very briefly what we are doing in relation to awareness raising.
Lamia was asking, what does the basic team consist of for the initial patient visit at your clinic? So we don't have a clinic. We do visit the patient at home. The core team consists of doctors and nurses, plus mental health support by psychologists as needed based on referral criteria. Annika was asking about the equity tool if it was developed in-house.
No.
Can we say that it will be published soon?
Yes, hopefully, yes. It wasn't published. It wasn't done in-house. It was done based on a tool that was developed by a professor, nursing professor in Colorado, if I'm not mistaken.
Yeah.
University of Colorado, and we did adapt it, to be honest. So we did do some changes, and we have worked on an quality improvement project that we um, wrote to publish. Let's hope it is. We just sent it to for review like few weeks back. We were yet to hear from the editors and reviewers about that, but we can definitely um, discuss access to this tool, of course, along with the professor that has been with us throughout this journey.
One last question. Given Lebanon's history of instability, what preparedness measures or contingency strategies has Sana developed to safeguard continuity of palliative care? I think you mean if we face future instabilities. I think so, right?
War.
War.
Referring to war, yes.
So there was a lot of lessons learned from war, from the war that we went through in 2024. And I think many things would be done the same way because many things turned out to have positive impact on the service. But what we would do differently, or what we would add, the layer that we would add is the layer related to reaching out for the patients who have palliative care need. I think that is what we are working on because that was the most difficult intervention we did during war, right, Farah?
Yeah, with the schools, you mean?
Yeah,
Yes.
because there was a lot of steps that we need to go through to be able to reach those people, and there was a lot of paperwork, possibly bureaucracy issues. So there was a lot
Safety
of
issues
delay.
as well. Safety
Yeah,
issues as well, yes.
and safety issues, of course, in the restricted areas. So what we would be working on additionally, in case it happens again, would be this layer of reaching out or reaching and screening for palliative care needs in a different way. So we would use a different process, definitely. I'm not sure if I answered your question, Hassan. This lecture was excellent. What if Sanad adopted the idea of establishing a community for palliative care providers in the Middle East? تفضلي فرح.
And I want to tell Lamia and probably yes, why not? I mean, there are several communities, just to say as well, to highlight in Lebanon, when it comes to palliative care providers, there is one nursing that was established in 2023 under the order, which is for palliative care, yeah, for nurses working in palliative care setting needs. There's one also for doctors. But yes, that would be maybe going beyond Lebanon. That would be a nice idea. Thank you so much, Lamia, for the suggestion. Absolutely. And Silva was saying that this is why probably. Oh, yes. Silva was saying that, yeah, thank you for the comment, Silva, regarding the resilience. And yeah, I mean, in palliative care we cannot not but do this. This is part of the mission and values of palliative care, is to stay standing and being there for patients no matter what. And it seems in crisis settings, palliative care needs increase, and the need for such an approach even doubles and triples. So it is suffering on top of another suffering. So there is a lot of compounded suffering when it comes to crises, and this is where palliative care should be. It's not that shouldn't be a luxury. It is not something that should be provided if available. It should be provided because it is the way where we reduce suffering and we address this issue. But yes, I'm talking about palliative care and humanitarian crisis, and Silva is doing some nice work on this as well. Hopefully, soon she will get some results. Along with our work that we are doing also with the camps, we will be able, hopefully, to do some good work on a national level. Fingers crossed as well. So the session with recording will be available ideally on the London Cancer Week website, and hopefully on our website as well, or on our social media. So we will put this and we will advertise it whenever we have it on, so that everyone who attended knows about this. Yes, we'll do. Shani will do. We'll share the recording. And Shani was having a question. Do you think resource limited settings must look at integration? Yes. Okay. This is a huge topic, integration at primary healthcare. Um, actually, we did try to approach that before the crisis, which is around 2018. And I would say the ground wasn't yet ready for that, given the many setup and factors that are in Lebanon that are related to primary. But I know that primary settings, but I do know, and several crises that the primary healthcare setting had to face as well because of the national crisis that happened in Lebanon. But I would say that moving forward, this is definitely a priority. It is one of the items that are there in the National Cancer Plan. And we are hoping when time is ready to start working on this, but this is a definite important area for work. We are just trying to prioritize things when it comes to such work, given the many pressing needs as well and the limited resources that the country is facing. But there is definitely, like looking back at it 5 years and now, the momentum has changed when it comes to palliative. Things are changing on national level as well in a positive way, slow but positive. But this is something reassuring for all of us who work in palliative. Thank you. Thank you, Dr. Ghada. Thank you so much for your nice words. And we are privileged to be working with Imam Sadr Foundation to support them on the development of their palliative care services. Thank you so much, Dr. Ghada. And thank you, everyone, for your very nice words. Huda, Asma, Eunice, Vicky, everyone.
Dr. Nidal, thank
Dr.
you.
Nidal. Yes. Thank you so much. I think we can wrap up. We had a lovely discussion, guys, with you all. Thank you so much. I'll keep the floor as well for Hala to say some final thoughts.
Thank you, everyone, for attending. It was a great session. I'm happy that you liked it. Hopefully you did. And thank you so much. I have nothing to add.
Thank you. You have a great day, evening, or afternoon, wherever you are. We hope to see you in other sessions. Follow us on our social media and take care.
Thank you. Goodbye.
Bye-bye.
Goodbye, everyone.